My name is Amminadab. I'm a PhD candidate at the School of Clinical Sciences at Monash University, and I'm presenting this work on behalf of my co-authors. Like elsewhere around the world, Australian patients with suspected stroke are usually advised to call for an ambulance. In the country, ambulance services can either be privately funded, covered by health insurance, or state-funded, as is the case for residents of Queensland and Tasmania. Most of the patients who use ambulances are transported to publicly funded hospitals where emergency stroke care is provided. Ambulance services and acute hospital care are managed by the state or territory rather than at the national level. Data systems available from different organizations function as silos, where routine data linkage between organizations such as ambulance service providers and hospitals does not exist. And so the aim of the current study is to test the feasibility of linking ambulance records with data from a clinical registry. We also aimed to look at the factors influencing identification of patients with stroke in the pre-hospital environment, as well as the factors influencing the provision of acute care for these patients. We conducted a cohort study using patient-level data from the clinical registry and ambulance records collected between 2015 and 2017. We used descriptive statistics and logistic regressions to explore factors associated with access to evidence-based therapy. The linked dataset includes ambulance records, the registry data, death records, and the hospital administrative data. I'll provide details of these datasets in the following slides. Just briefly, the OSCA commenced in 2009 to monitor acute care of patients with stroke, or TIA, transient ischemic attack. The register collects demographic information as well as treatments provided to patients during hospitalizations. And these include care in a stroke unit, provision of reperfusion therapy, and other important processes of care. The registrants are also followed up at 90 to 180 days after stroke admission to determine their quality of life. The registry data are linked to the National Death Registry every year to ascertain mortality for these patients. Ambulance Victoria is the sole provider of emergency medical services in the state of Victoria. In case you're wondering, it is that state with the shaded in blue. It collects both operational and clinical data for its performance measurement and funding purposes. Operational data are captured through a computer dispatch system, whereas the clinical data are captured by paramedics during patient management on the field. The paramedics use the Victorian Ambulance Clinical Information System to capture the data. The Victorian Department of Health collects information on hospital admissions and emergency presentation that assist in service planning and case mix funding. These data include details for every emergency presentation and admitted episode of care occurring in Victorian public and private hospitals. For this study, the OSCA provides the source of patients with hospital-confirmed stroke, or TIA, and by linking this data with the ambulance records and the administrative datasets, we can identify the factors that influence the pre-hospital and hospital care for patients with stroke, and also determine their long-term outcomes. The final cohort consisted of just over 4,700 cases of stroke, with under half of these recorded in female patients. Lights and sirens were dispatched for 81% of the patients, and paramedics used the Melbourne Ambulance Stroke Screen, or MAS, in 81% of the patients, and documented pre-notification of arrival at the receiving hospital in 44% of the patients transported to hospital. The use of MAS and pre-notification was higher in those patients suspected of stroke or TIA by paramedics. And just to briefly explain the MAS, It is a validated tool, which is a combination of the Los Angeles pre-hospital stroke screen and the Cincinnati pre-hospital stroke scale tools. It draws on the strength of both tools, providing equivalent sensitivity to the Cincinnati tool and equivalent specificity to the Los Angeles tool. And so the MAS provides better overall accuracy in diagnosis than either tools alone. The MAS tool has been in use since 2005, and paramedics are encouraged to use it if they suspect a patient is having a stroke in the pre-hospital environment. Looking at the factors associated with correctly identifying a stroke, female patients were less likely to be identified, whereas those with less severe stroke were more likely to be identified as having a stroke by call dispatches. Here, ability to work on admission is used as a proxy for stroke severity. I suspect that those with less severe stroke are able to explain their symptoms to the call dispatches and therefore are more likely to be identified. Patients who arrived at regional hospitals and those with symptom onset within 4.5 hours were more likely to be identified by paramedics as having a stroke. Again, patients identified as not having a stroke were less likely to have time-critical ambulances dispatched by call dispatches. Paramedics were also more likely to use the MAS tool and notify receiving hospital for patients suspected of stroke. The strong correlation for use of MAS by paramedics is unsurprising, as paramedics are expected to use this tool for patients suspected of stroke in the pre-hospital environment, as I mentioned earlier. When we examine time intervals, patients suspected of stroke were more likely to have a shorter median time for arriving at hospital and triage time when we compare patients suspected of stroke and those not suspected of stroke by paramedics. Patients correctly identified by paramedics as having a stroke were more likely to benefit from care processes such as receiving thrombolysis for ischemic stroke, screening for speech, and swallowing assessment. These data demonstrate the successful linkage of ambulance records to a stroke clinical registry never been attempted previously in Australia. In our preliminary analysis, we have found females and patients with symptoms of stroke onset more than 4.5 hours less likely to be identified by ambulance staff. Patients not identified as having a stroke by call dispatches were less likely to receive highest priority dispatch ambulances, and those patients identified as not having a stroke, and those patients identified as having a stroke by paramedics benefited from care processes such as thrombolysis and stroke unit care. One benefit of the ambulance data is that it supplements the information collected in the stroke registry and it allows us to understand important factors in the pre-hospital environment, such as ambulance ramping. We plan to undertake further analysis looking at system factors influencing the provision of care and whether these influence the outcomes for patients 6 months after stroke. I would like to thank my supervisors and the team here at the Stroke and Aging Research, my collaborators at Ambulance Victoria, and the OSCAR Consortium partners. Thank you.